And that means also that we have to look at the bone microenvironment and trying to see how their bone metastasis can be prevented. And the rank ligand being one of the preventing targets of bone metastasis has been investigated several years or decades before and shown that this rank ligand inhibitor may then really increase the survival without bone metastasis as a prevention of developing bone metastasis because of the interruption between the rank ligand and those tumor cells that increase the osteoclasts and therefore or inhibit osteoplastic formation, thereby then leading to the osteoplastic metastasis. And also it has shown that apparently the primary treatment, the primary identification of clonal prostate cancer cells will then eventually lead or inhibit the development of bone metastasis and its increase in the entire bone system. But rank and rank ligands not only occur in the entire in the bone, but also in other organs or systems of the bone and lymph nodes and other organs do play a role. So we may think that some of the rank ligand inhibitors may help in getting the entire body involvement of prostate cancer metastasis then influenced. But again, work in progress, and is that rank ligand is a mediator for osteoclast formation and function and survival in bone metastasis. And denosumab, as also previously mentioned, not only for prostate cancer but for other tumors, of course, given in a monthly dose every 4 weeks, does lead to a prevention of the skeletal-related events, SRE, and it has been approved in Germany and, to my knowledge, in Europe and other parts of the world for the treatment of prostate cancer-related, skeletal-related events. And what happens here is that the denosumab binds as a monoclonal antibody to human rank ligands, and so thus it prevents the rank ligand from activating the receptor rank, and thus the stimulation of osteoclasts. Now, we have been talking about survival, overall survival. And of course, in metastatic castration-resistant prostate cancer, we try to increase overall survival. But overall survival does not always mean that we really improve the quality of life for the increased survival period. And so it must be our aim, and that is why it is important to think about the symptomatic relief of bone metastasis by thus increasing also not only overall survival, but also the quality of life of these patients. And that means, for example, that the time to opioid use, the time to treat severe pain with bone-targeted therapy is really prolonged. Saying, in other words, you can defer the opioid use of bone metastasis with the help of bone-targeted therapy. Let me get to a case, a young, fairly young case, a couple of years ago, who um, was shown with an increase in PSA, and thus an MRI was done, as it's now in the guidelines of the both the European and the German guidelines before you go ahead and do a biopsy. And already it was seen that not only his PSA was elevated and that there was a suspicious lesion in the prostate, but also there was an osteoplastic bone metastasis in the right superior pubic ramus. A single metastasis, bone metastasis. So it is an oligometastatic disease. And of course, now we do have access, and in Germany, actually, for 10 to 15 years, not sorry, PET-CT with previously with glucose tracer, and later on with a colon tracer, and more recently with the PSMA tracer was available. And it showed there was no lymph nodes in this gentleman. The PSMA overexpression in the right lobe of the prostate, as you can see here, but the PSMA positive lesion in the right pubic ramus. Single metastasis. Yeah, what should we do? Shall we do just give him a hormonal therapy? That what we would have probably done 10 years ago. Should we radiate the prostate and hormonal therapy? Should metastasis directed treatment? And should we be radical and do a radical prostatectomy and radiation to the bone, and with or without ADT? The current guidelines would recommend, it's an oligometastatic disease, so you can think about radiation of the prostate, and you would probably do an hormonal therapy plus a new androgen receptor inhibitor. And that is something that could be done. Of course, you could think in a very young patients, even in not only doing a local therapy with radiation to the prostate, a double hormonal therapy, but also then maybe do a metastasis-directed therapy, especially if it's symptomatic. Then it would be something that the guidelines would support it. If not, then it is a very individual therapy and not guideline directed, but it could be done. And actually, to be honest, it has been done like that. And with that, the patients remained non in under hormonal therapy. He had no PSA. The PSA was non-measurable. So guidelines, yes, they have changed, treating in the primary organ and also the hormonal therapy. But individually, of course, you could go ahead and do the thing. This is a very busy slide. It is the what is currently used in prostate cancer with bone metastasis. Yes, vitamin D and calcium supplementation. Don't forget about that. Also, exercise, it helps. Anti-resorptive therapy, it's approved in Germany, zoledronic acid, given 4 weekly, but there are data now that it may be given, as my previous speaker has already said, over treatment. If you give it monthly, it could be given every 3 months. Denosumab every 4 weeks in a dosage of 120 milligrams. It both denosumab and zoledronic acid do reduce the skeletal-related events in metastatic bone metastatic castration-resistant prostate cancer. However, there's no sign that it does actually improve overall survival. The radium-223 for symptomatic bone metastasis in metastatic CRPC is still an option. Is still an option despite the ligand therapy. I didn't go into ligand therapy because it's not a particular bone related treatment. Patients that do get a hormonal ablation therapy, the use of denosumab at half dosage, 60 milligrams, we call it Prolia, every 6 months, increases the bone mineral density. We think that patients that are on hormonal ablation therapy for prostate cancer, they lose the bone density by 4% every year of the hormonal therapy, and that's why denosumab may be helpful here. And denosumab, as I said, again, together with, not together, or zoledronic acid, may be used on a 4-weekly basis. Zoledronic acid may be only at 3 months incidence. Think about the renal function and the fact that it should be given in an infusion minimum 15 minutes. Better, I always do it. And again, like in breast cancer, when discontinuing anti-resorptive therapy, we have to be careful about a rebound bone resorption. So in short, the bone-targeted agents, bisphosphonate and denosumab, are approved and should be applied. Supplementation with calcium and vitamin D, together with exercise, by the way, is a way of bone prevention, bone health prevention, radiotherapy for symptomatic control. In a single bone metastasis, to be discussed as a treatment form in the oligometastatic disease, surgical interventions when indicated only for symptomatic reasons, and the monitoring for the side effects, osteonecrosis of the jaw and hypocalcemia, are basically every patient should be seen by a dentist or maxillodentist specialist, maxillofacial surgeon specialist for seeing if there is any possible risk factors, and anything that is done which the dentist does, which leads to bleeding. I always put it very simple. That should be avoided under the treatment of biphosphonates and denosumab. So this is just in short what relates to the bone metastasis and bone health in bone metastatic advanced prostate cancer.